My name is Dr. Ahmad Alanezi. I am from Kuwait, and I'm very pleased that I'm going to present this lecture to you this afternoon. The title of today's lecture is Rehabilitation of an Edentulous Patient in the Digital Era. In this presentation, we will discuss what are the thought process that we take in order to reach digital planning and execution during an implant treatment, as well as discuss what are the surgical and the prosthetic aspect that the digital technology will help us in. Before we begin, my name is Ahmed Alanezi. I'm from Kuwait. I graduated from Mohammed bin Rashid University and did my prosthodontics training there, as well as joined Harvard School of Dental Medicine to do an implant residency. In this case, I'm presenting, that was during my residency in Harvard School of Dental Medicine. In order to, before we jump into the case, we need to define what is a complete digital workflow. Usually they are divided into 5 stages. And the first stage, and it's the most important stage, is the comprehensive evaluation. During this stage, you really want to have a global analysis of the patient. You want to know the patient dental, your patient occlusal, and periodontal evaluation and assessment. You also want to have a good radiographic analysis. You want to know whether the patient is candidate for dental implantology or not. You want to know the risk factors the patient possess when you design or plan this kind of treatment. And after done a thorough evaluation, you can move into the data acquisition phase, which is mainly digitizing your patient. And the way you can do this with the three tools. One is a cone beam CT to get your DICOM file, and then the second is an intraoral scan, and the third will be a 2D photograph or a 3D facial scan. After having these data, you will be able to perform a virtual planning. During the virtual planning phase, you will be able to superimpose these data together, the DICOM with the iOS file. You'll be able to know what type of implant you're going to place. You're going to know the diameter and length, and most importantly, you'll be able to know the virtual abutment before you even start your surgery. You'll be able to design your guide, and then once you design your guide in the virtual planning, you can move into the CAD/CAM technology, and it can be either milled or printed, and you can mill or print your prosthesis or your guide, and you'll be able to perform your guided implant surgery. Let's jump to the case. This patient, he came to the clinic looking for a second consultation. He's a male, 30 years old, relatively a very young age, and he wants an implant teeth. The patient medical history revealed that he has trichomalacia. And trichomalacia is a condition where the trachea is actually deficient. It cannot clear the fluid or secretion from the lung. And this is especially important when we are designing our denture, because sometimes the denture can accumulate some of the mucus, and the patient reported that his previous denture accumulated mucus and made him have a coughing attacks. And those coughing attacks sometimes developed respiratory illnesses and pneumonia. So we wanted to know that the denture, that we wanted to know how good of a candidate the patient is for a complete denture, because it's also one of the main things that we rely on when rehabilitating an edentulous arch. Okay, a series of extraoral photographs, and these are very important photographs. What we wanted to know is we wanted to see the overall facial features of the patient, and we also wanted to know that if the patient is exhibiting a lot of ridge when he's on a full smile. Let's say the patient is exhibiting a lot of ridge, maxillary arch ridge showing, then you know that from the get-go that this patient is a candidate for a ridge reduction. And why I'm saying this, I'm just like talking to you into the thought process, what we do when we are planning a case like that. Facial analysis is important. We found out that the lip support to the nasolabial angle here is within 90 degrees, which is without the prosthesis, so which is a good number. And this is the patient intraoral situation. We found out the patient is edentulous in both upper and lower arch. The patient is having a large tongue space, which is a diagnostic feature, knowing that your complete denture may not be retentive if you put it as interim prosthesis. Also, the patient is having high muscle attachment. The occlusal view, you find out that the upper arch is well developed, with the oval arch shape. The oval arch shape also is a diagnostic feature to know how many implants you're going to place and where are you going to place your implants. And there's a good band of keratinized tissue, which indicate that you may be able to go with a flapless approach here. The lower arch is also the same, that there is a presence of high muscle attachment. However, if you pay attention to the anterior aspect of the lower arch, you find that there is a lack of keratinized tissue, especially on the buccal aspect. And this is especially important because if you are planning for a flapless approach, you might not want to do it in this case. You want to open a flap and then place your implant and then cover it up, or to not lose this kind of band of keratinized tissue. The treatment plan were given to the patient, and the patient chose implant-supported fixed prosthesis. And because the patient chose implant-supported fixed prosthesis, we need to first design a diagnostic denture. And this is the most important step in your planning, is designing a good diagnostic denture that have a good occlusal scheme as well as representing good facial features. And this is the patient wearing the denture. And then we also wanted to evaluate the interappropriate line with the incisal plane line, as well as we wanted to know whether the midline is in the center or not, because this denture will serve as a prosthetic template for your implant planning for everything that comes after that. Not only we did the denture, we did the flangeless denture as well. And we wanted to know the incisal plane, you wanted to evaluate the lip support and the teeth display and the buccal corridor. And once we are happy with this, we can take those dentures and put them in a dual scan protocol, as discussed earlier from our previous colleague. We need to put the fiducial markers in our dentures and perform 2 sets of scans. As the name suggests, it's a dual scan protocol. The first scan will be from the denture itself, and the first scan will be the denture itself. The second scan will be the patient wearing the denture. You want the patient to occlude, okay, rather than put a cotton roll. So you have the upper and lower together, as well as after acquiring all these data, you can import this information and put it in your virtual planning software. So you can use this diagnostic denture in order to plan your implant and to plan your future prosthetic and your surgical guide. This is the virtual planning. This is the initial situation after we had all these data imported. This is the approved denture that we discussed earlier. And this is the new prosthetic that we made, because in this case, we are going for an FP1 at the top and FP2 or FP3 in the bottom. We also wanted to make sure that the occlusal scheme in this kind of situation is either canine guidance or occlusal function or groove function. And this an article by Professor Humlei Wang suggesting that, with each implant fixed prosthesis, you have a different type of approach. So I suggest that if someone is interested in what kind of occlusal scheme should be done for his patient, to look at this lecture. There are a set of series or questions that I need to ask myself when I plan an implant case. And one of them is, what is the implant design I'm going to use? And in this case, I wanted to use an aggressive thread implant design. And the reason for that is because I wanted to ensure high torque or a high insertion torque during my implant placement, as well as I wanted to load my prosthesis on the same day of surgery and have the patient leave out of the office with a prosthesis, with a converted prosthesis. And we have strategically chose this kind of implant, and many thanks to Megagen for being a pioneer in this aspect with the annuage design. We also wanted to know how many implants are we going to place in the maxilla. We decided in 8 implants, while in the mandible in 6. The reason why we decided 8, because the arch is oval, and we also wanted to do a segmented prosthesis rather than splinted, especially after knowing the patient is in a young age. So if down the road, as we all know that prosthetic implant prosthetic, they have complication in 5 or 10 years. So if the patient have a complication in one segment, we can remove it and we can repair it rather than removing the whole thing, and repairing the whole thing will be much costly. The prosthetic abutment, we are going to have our prosthesis on the multi-unit. We don't want to go direct to the fixture, and the reason for that, we don't want to disturb the peri-implant mucosa in that area. And I'll show you an article by my program director, Dr. Gulucci, saying that different type of abutment design will negatively impact the marginal bone loss around it. The final prosthetic design will be FV2 in the mandible and FV1 in the maxilla. The final prosthetic material will be monolithic zirconia, and the type of the prosthesis, as we discussed, segmented in the upper and splinted in the lower. And this is a paper that I collected saying that, when you are planning for immediate implant placement and immediate provisionalization, the biological and prosthetic complications are rare. But I would read this and caution that, knowing that you have addressed all the risk factors beforehand. And this is another article. It's a histological and micro CT analysis of changing the healing abutment or for the implant. And they found out that they influence the marginal bone loss. So if you have an abutment one time, the risk of having a bone remodeling around the neck of your implant is much less. This is a virtual mock-up, so we superimpose everything just to make sure that everything is in place, because now we will rely on this mock-up to design our implant, to design our guide and everything. So this is the maxillary arch, and we have placed all our implants, and we have strategically chosen the position because we are going for a segmented approach. We placed our implants facially driven because we relied on the face, as well as prosthetically driven. We selectively chose our abutment, the prosthesis type and the design, and we were avoiding the vital structures when we are planning. Same thing in the mandible, and I want to show you like how the SRA are virtually selected. So during the surgery, you don't have to waste or use multiple SRAs just for a single site. That was one of the main benefits of having a virtually selected abutments. And this is the upper and lower. We knew that in size number 14, we're going to go subcrystal sinus approach, and size number 3, our implants are fully placed in the best position possible. And we were able to select our implant height and width, as well as we were able to select the virtual abutment and corresponding to the prosthetic plan. That's a lower arch as well. And in this case, we decided to go with sequential guide. Also, they called it as a pin supported guide. So use the denture with a pin on the denture itself. And these pins will serve as a common reference between the next two guides. And then after having the fixation pin guides, then we can place our drill guides and then the guided prosthetic, as I will show in the next slides. So this is the fixation pin guides on the day of surgery. And this is a mucosa supported guide just to place our fixation pins. But we also have to realize that we need to replicate the occlusal scheme of the guide, both in the denture. It should be similar to the prosthesis that you are to the guide that you're making. And this is the anchoring pin placed. And what I want to tell you here, that if you are placing anchoring pin, you want to go left, then right, then middle, instead of going one side to another. Because if you go from one side to another side, you will introduce a lot of inaccuracy. And you will be able to have your guide as planned in your virtual plan. Then you move into the next guide, which is the drill guide, and you put your drill guide. The difficulty here, sometimes the mucosa act as a barrier, so you'll be struggling placing those pins. And the solution for that one is to place the pins in attached mucosa rather than in non-attached mucosa or keratinized mucosa. And the second is to increase the number of pins as much as possible, but make sure the posterior pins are facially placed, so you can easily put them and remove them during surgery. Our implants were drilled in a fully guided fashion. We have a surgical protocol guide. This will serve us as a guide or a template, but you don't have to follow it because, during the surgery, you might run into weak bone or a strong bone, and it might be different in case by case. And this is our implant, fully guided, placed. This is our multi-unit and multi-cylinder placed and torqued. And you can see that our temp cylinders are exiting from our predetermined channels, which means that we are succeeding in this execution. This is the prosthetic, and this is the day of the surgery, and this is the patient leaves on the first day. Next week, the patient comes, similar procedure applies. The only thing in this that we had to open a flap in the lower to preserve the band of keratinized tissue. We placed our multi-unit abutment. We made sure that I have enough space around our multi-unit abutment. Our temp cylinders were also placed. Our prostheses were placed and picked. And as you can see, they are exiting from our predetermined channels. Then this is our prosthetic, and this is how the patient have his prosthesis on the same day of the surgery. And this is the post-op OPG. Then couple of months after 3 months after, the patient comes for digital impression and a CAD/CAM designing. Then this is how eventually the patient started with, and this is the patient how he left, and we wait for another 3 or 4 months for the patient to test drive those prostheses. That's our OPG. This is our patient again, orally. And with that, I would like to thank you so much for your time and for your attention. I'd like to thank my faculty for their support and helping me throughout this case. Thank you very much.